you've given me some hope, which I think is not what I expected at the end of this conversation. So I'm really, really pleased by that. Welcome once again to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who is as confused by the latest health study as I am by the difference between a hurricane and a cyclone and the many other terms. So we're going to be talking about hurricanes and cyclones. Can either of you explain to me what the difference is?
I'm turning to Amruta.
So hurricanes are the things that happen in the Atlantic basin, and cyclones are the things that happen in the Pacific basin.
But this paper talks about hurricanes and cyclones.
They're
and
used
it's all
basically
about the US.
interchangeably.
And differentiates on the basis of wind speed.
Yeah,
right?
so that you can do tropical storms, you can do hurricanes. That's differentiated based on the wind speed.
Is it fair, though, that I'm confused?
Yes.
Okay.
Absolutely fair.
This one stumped me because every time I tried to look it up, I would get different definitions. And I had heard exactly what you said about the Atlantic and the Pacific, but this paper is solely about the U.S. and it talks about cyclones and hurricanes. Okay. All right. Well, anyway, I am Matt Fox from the Departments of Epidemiology and Global Health from the Boston University School of Public Health, and I am joined once again by friend and co-host Dr. Jessica Liebler from the Department of Environmental Health here at the BU School of Public Health. Welcome, Jess.
Thanks, Matt.
And we have a fantastic guest today, Dr. Amruta Nori-Sarma, also from the Department of Environmental Health here at the BU School of Public Health. Welcome, Amruta.
Thank you so much for having me.
Glad to have you. So as a reminder to everyone, head on over to the Population Health Exchange website at www.pophealthex.org. That's BU's hub for lifelong learning. And also a reminder to go onto your favorite podcast app, iTunes, Stitcher, whatever you use, and give us a rating. It really helps other people find us. And I also want to announce that we are kicking off a series of podcast episodes that we are going to be doing, which are being done in relation to the Boston University School of Public Health Strategic Research Directions. So these are a series of research areas that our School of Public Health has strengthened and is interested in investing in growing. Those areas are cities and health, climate, the planet and health, health inequities, infectious diseases, and mental and behavioral health. And so today we are going to be focused on that climate, the planet, and health segment. And that gets us to our topic for today. So on to the show. So in our first segment, that's our journal club, we're going to talk about a study on the effects of tropical cyclones and mortality in the U.S. Then in the second part of the podcast, which is our deep dive, we're going to talk about why a hotter world is affecting different people and different places in different ways. And then in our third segment, which is our amazing and amusing, we will get into some things that make us laugh out loud or just really interested us. So segment one. So we're talking about an article that looked at the effects of tropical cyclones on mortality. It was published in JAMA, and it was entitled Association of Tropical Cyclones with County-Level Mortality in the U.S. by first author Robbie Parks of the Department of Environmental Health Sciences at Columbia University's Mailman School of Public Health. Some headlines on this one. So The Hill says hurricanes linked to 33% surge in death rates after storms. USnews.com says more hurricanes mean rising death tolls for Americans. And Yahoo says hidden burden. Hurricanes keep killing people long after landfall, study suggests. I always like the study suggests, implying that they may have their doubts. I don't know. I don't have doubts. But so Jess, can you walk us through this study and what they did and what they found?
I can. So this was a really interesting study, and thanks to Amruta for bringing it to our attention, as it's different from some of the studies we've talked about in the podcast before. So as many of us are familiar with, there's a good deal of literature and media and other reporting kind of detailing immediate public health consequences of hurricanes and cyclones in the immediate aftermath as these events are happening and in the immediate aftermath, including increased hospital admissions and then consequences for employment, for schooling, mental health, for the economy, and other sorts of things in the immediate time, both during and the immediate aftermath of a hurricane. in the United States. But much less is focused on these longer-term effects of hurricanes and cyclones, which these authors are calling the indirect associations, specifically indirect associations with mortality or associated mortality with a time lag after an initial extreme weather event like a hurricane or a cyclone. So that is what these authors are looking at. They're considering cause-specific consequences, cause-specific mortality of tropical cyclones in the United States, and they considered stratification by a number of factors, by age group, by gender, and by socioeconomic vulnerability. And this article, well, I'm sure we'll talk about it in more detail, but one of the things that I thought was particularly elegant is that they did not use a tremendous number of confounding variables or stratification variables, and they kind of kept it fairly straightforward. They had complicated mathematical approaches and statistical approaches, but the essence of the model was pretty simple. What they were looking at was the cause-specific mortality associated with hurricanes and cyclones with a time lag in the United States. They looked at weather data and mortality data on the county level in the United States from 1988 to 2018, so a 31-year period, to evaluate the whether exposure to a tropical cyclone on the county level was associated with increase in county-level cause-specific death rates in the months following this weather event. This was a retrospective observational analysis, and counties were included in the study if they'd experienced at least one tropical cyclone event during the study period. The death data, including the number of deaths, the county of residence, and the date and the cause of death, were derived from the National Center for Health Statistics. And they reported mortality from 7 causes: from cancer, cardiovascular disease, infection and parasitic disease, injuries, neuropsychiatric conditions, respiratory diseases, and their final category just of other diseases. And then the other disease category they did not include in their analyses because it was considered to be too diverse in terms of those other causes. They looked at social vulnerability on the county level using the CDC's Social Vulnerability Index, the SVI, that many of us in environmental health use across many different studies. And the SVI is an index that includes data effectively derived from the census on socioeconomic status, household size, minority status, and other sorts of factors that can be related to social vulnerability. Cyclones, their core exposure, were defined on the basis of wind speed. We were talking about this a little bit earlier, and characterized by county affected and month into either tropical cyclones, which were characterized as greater than 34 knots wind speed, or hurricanes, which were the bigger ones, greater than 64 knots of wind speed. They also looked at temperature, mean temperature by month, using the PRISM climate mapping system in a sensitivity analysis. So their core statistical approach, they took this Bayesian formulation, which we can talk about a little bit later, Bayesian formulation of a conditional quasi-Poisson model, including lag terms up to 6 months after the cyclone itself. And what this approach did, which is very interesting on a kind of conceptual, intuitive level, is it allows for the comparisons of death rate across the same month in other years, controlling for the various factors that they have in their model, so socioeconomic status and other potential confounders that would more or less remain static by county, with the exception over time, with the exception of the weather event. And the Bayesian approach allows for kind of incorporation of a distribution around a given estimate, which allows them to add some robustness to the model estimates. And I'm sure we'll talk a little bit about some of these approaches and pros and cons. The output of the model is the additional death rate. So they modeled the incremental additional death rate associated with one additional county level cyclone day per month. And they also estimated actual deaths associated with these weather events. And they stratified the results by various factors, as I talked about. They also used the credible interval, which I'll look to Matt also to talk about, which is used in Bayesian analyses, reflecting the posterior probability distribution instead of the confidence interval, and which is associated to have more randomness to it. But we can talk about that as well. And so they were presenting these estimates alongside the credible interval. They included about 1,200 counties in their analysis, which reflected a little less than 50% of the U.S. population during their 31-year study period that experienced at least one cyclone event over this period of time. And they found a positive association between exposure to cyclone hurricanes and the overall death rate by county, with the strongest effect seen for death rates from injuries over this time period. And so, interestingly, and I think the injury was kind of one of their key their key findings, and although they looked across these 6 other outcomes. So the mortality rate associated with cyclone for injury peaked 1 month after the cyclone, and they found it was a 3.7 increase in the death rate associated with 1 additional day of exposure to cyclone. So that's a 3.7 increase in death rate from injury associated with a 1 additional day cyclone exposure on the county level. So it's a bit of a mouthful.
3.7%? Percent.
Yep. Sorry, 3.7% increase in the death rate associated with 1 additional day of cyclone exposure on the county level, which they estimated resulted in a predicted 55 additional deaths per month associated with the cyclone by injury. And so injury was the big finding here, that it was highest among people over 65 in the first 2 months after the cyclone event, and also higher in females compared to males. The death rate from injury was most pronounced in the most vulnerable SVI tertiles. They looked at the social vulnerability index in tertiles compared to the lowest tertile, with the difference also peaking in the first month after the cyclone. And they saw also a particularly strong effect as it related to injury from hurricane compared to cyclone exposure, with a more than 3 times the risk of injury from death from a hurricane compared to a cyclone. They also found increased death rates from most of the other causes that they looked at, including infectious and parasitic diseases and respiratory disease rates, which peaked 1 month after the cyclone or hurricane event, although the marginal increases in the death rate were quite a bit smaller. But they did see a stronger effect for hurricane versus cyclone in this few-month period following the actual event. Similarly to cardiovascular disease and neuropsychiatric conditions, death rates associated with these 2 factors also were increased in the 1 month, and some of them in the 2nd month after cyclones and hurricanes, but at a much smaller rate than injury. And they saw no association with cancer. They saw no change in cancer mortality associated with these exposures. So the authors concluded that there is an association between cyclones and hurricanes and specific cause mortality in these affected counties, with their specific positive association focused on death from injury, but they did note other increases in death associated with other conditions, specifically infectious and parasitic disease, cardiovascular disease, and a smaller effect associated with neuropsychiatric conditions resulting in death.
So a lot going on here. And in some ways, I would say some of this is probably not particularly surprising. I mean, finding out that injuries, death-related injuries after tropical cyclones is not particularly surprising, although it's one of those things that you really need to quantify, whereas some of the other findings I actually think are maybe not surprising, but are pretty interesting. And I think in chatting beforehand, I think we all felt like this was a good study, that we liked it. We could find some things to critique about it. But Amruta, what's your take on this study? What did you like? What did you not like?
So yeah, I think this is a really fantastic study. I think that the area of research looking at the health implications, both morbidity and mortality implications of extreme weather events, is a relatively new area of research. And one of the things that I think is really exciting is that we've been able to, as a field, generate a lot of data on the exposure side. So I just want to focus on that piece for a minute, because I think one of the challenges in climate and health research is that there don't exist these very nicely packaged pre-existing definitions of what constitutes an extreme weather event. And a lot of times we do have to rely on a lot of disparate data sources to come up with combinations of things that might be relevant when we're talking about different types of extreme weather. So in the hurricane example, what Robbie has done really well in this paper, and what he and his collaborators have discussed quite in depth, is that they've used these wind speed metrics to determine what is a tropical cyclone, what is a hurricane. Some other examples that we might think about in terms of hurricane exposures might be things like flooding, extreme precipitation. So there's a whole host of different exposures that are very relevant when you're referring to an extreme storm event. And so what I think they've been able to do really nicely is assign their exposure metric at the different levels that are of interest. So looking at lower wind speeds and lower wind frequencies to define the tropical cyclone, and then the higher wind speed to define the hurricane. And then so you kind of get this really nice dose response. So you're looking at, what is the increase in the mortalities that are occurring as a result of exposure to tropical cyclones compared to hurricanes. And so I think that provides us with a really nice context of, okay, here's how we see differences in the mortality impacts across these different types of severe exposures for extreme weather. And so I think that's a really nice characteristic of this paper. And in terms terms of the methods that they've used, I really do like the conditional model that they've used and the framework that they've set up. I think it lends itself really nicely to dealing with some of the issues that we think about when we're looking at the best control days to compare with the extreme weather event days. And this is another feature of climate epidemiology that I think can be relatively challenging, is how do you actually try to come to some sort of causal inference regarding the relationship between the extreme exposure and the health outcome that you're interested in looking at. And so I think that what they've been able to do in this framework is they've been able to match the case counties with control counties that have a lot of the same time varying characteristics and also a lot of the same potential features of the populations that are being studied over the course of time as well. And so this is another one of the things that we were maybe discussing briefly in the beginning or before in talking beforehand. But I do think that the matching strategy that they've used allows us to start to make some of these linkages between the exposure of interest and the mortality outcomes that we're interested in.
So that's fascinating. So can either of you tell me, is this ecologic data or is this patient, not patient level, individual level data? I mean, it feels to me like it's ecologic, meaning it's we're just looking at overall summaries of what's happening in a particular county. On the other hand, they know all the people in the particular county. They know the population, and therefore they can relate it to an actual rate where you could create individual records. I struggled a little bit trying to figure that out.
My understanding is that this would be considered ecological data because they're not using individual level exposure data. They have individual level death data that then is attributed to the county. Mm-hmm. So is scaled up to the geographic unit. And the exposure likewise is scaled to that same geographic unit, not to the individual. So all of the individuals within the county share the same exposure data. That's a question. Does that?
I don't think that in and of itself means it couldn't be. I mean, I agree with you. And that's where I sort of was going with it. Certainly the exposure, it's the same. But I mean, that would be true. Let's say if we did a cluster randomized trial with individuals, everybody would get the same exposure within a unit. We'd still wouldn't call that ecologic. So I struggle with this one. The confounders that they used are not specific to the individual, right? So they were not adjusting for whether I personally am older or younger or, those sorts of things are, I think, being done at the level of the county. So that would suggest ecologic. On the other hand, I wasn't totally sure. I'm not sure it matters, but I'm just pointing out I couldn't suss that out.
I actually tend to think of this study design, and there are a few other study designs that I think are becoming more popular in the world of climate epidemiology. The other one would be the case crossover study design, for example. I tend to think of these as ecologic analyses. I think, you're able to aggregate individual level data at the county level, as Jessica was mentioning earlier, in order to make use of differences in exposures at that larger spatial unit that I think would be very, very difficult to do at the individual level, assigning specific exposures. And functionally, when we're talking about a hurricane exposure, if you're in a county that has a hurricane, you're in a county that has a hurricane. Functionally, in order to be able to leverage individual data, we would expect that there would be some differential in the exposure, right? If we wanted to take it down to the even more disaggregated unit. But in this case, if you live in a county with a hurricane, then you're exposed to the hurricane. So, you can think of other study designs that have been used to study more spatially varying exposures that might be of interest, especially in the climate world. And in that case, I think it does make sense to take into consideration, is this an individual level study versus is this an ecologic level study? And I guess in this context, it's not really clear to me that we would gain any benefit from using specific individual level data.
So let me, and I think that's a really good answer. I suppose though, you aren't necessarily exposed just because you live in the county, right? I mean, in fact, they talk about that in their discussion. I mean, some people leave the county when there's a hurricane coming, and those people are not technically exposed. And then you could talk about a different exposure, which isn't specifically the hurricane happened or it didn't. You could talk about your individual level exposure in the sense of, some people live in housing that would be more vulnerable at the time. So there's different ways you could play it out, but I take your general point. I mean, I do get the idea that it does make sense that it is it's reasonable to think of everybody in the county as being exposed, even if they aren't necessarily.
Right. And I think that the other thing that I would differentiate maybe in what you were just saying is that it is true that there may be some folks who have characteristics at the individual level that make them more vulnerable during the period of hurricane. But I think that's an important thing to distinguish from whether or not people are getting exposed to the hurricane itself.
Yeah, and you could also just think of it as the hurricane is the exposure, and then there are mediators
exactly
that would protect you, like moving out or type of housing or all those things.
I had a question. I guess
Sure.
I had two questions. One of them relates to the topic you just brought up, which is the idea that people often leave after a hurricane. And I was wondering, or before. But I was thinking specifically about people who might experience the hurricane and then leave because schools are closed or their house is flooded. And so they're exposed. But then if they experience a mortality endpoint, it's somewhere else. And I didn't quite get the sense as to how the authors characterize that, because that would lead to that. I mean, that seems to be that would be some sort of misclassification, that their death would be misclassified as a county potentially unexposed to the hurricane, but their death was due to the hurricane. And my understanding is there's a lot of mobility post huge weather event,
right? Before and after,
but that could really lead to an underestimate of these associations.
Yeah, and I think that they do address that as one of the major limitations, that they're making the assumption that this is an underestimate of the actual burden of mortality associated with these hurricane periods. And I think that's a really excellent question, and I think it brings up a lot of really interesting components of vulnerability that we don't really have a good way of getting at, because, and this is something that I think is a feature of studies like this that are looking across these longer periods of time and looking across multiple hurricane events. So some of the work that you mentioned when you were talking in the introduction and just introducing the paper has been studies, for example, Hurricane Katrina is very famous, also Superstorm Sandy, have been studies that have been focused on these particular extreme events and looking at what happens during the event and in the immediate aftermath of the event. And so I think one of the things that we gain is the power to look at these differences across different, potential, effect modifiers that we've seen in this study. We gain that ability because we're able to look across all of these different storms, which we may not be able to do if we looked at a single storm event. But, in order to be able to really track people and say, okay, can we look at who's moving and who's staying put and what are the differentials in health outcomes between those folks, that really requires a more in-depth focus on one particular storm event. And so I think there are trade-offs, and maybe going back to what we were saying before about discussing the pros and cons of this type of study design, we definitely aren't able to, another thing that I could think of as a potential limitation of this study is that we're not looking at subclinical outcomes. We're not looking at all of the different impacts that are happening that are short of somebody passing away because of their exposure to a hurricane, for example. So I think there are definitely pros and cons to this study design.
Can I ask you another question?
Sure.
My question, and this for Matt as well, is kind of, when you look at these studies that just look at mortality across different types of mortality, what I always think about is for each of those endpoints, there are different biological pathways that would link exposure to an extreme weather event and death. And, we have to, I think in this literature, there's a good amount of understanding about injury and about mental health in particular, that those could be two consequences. You could see people are struggling to rebuild and there's an injury, and that's kind of one pathway. And then there's obviously a lot of stress that could be associated. One of the challenges I thought was kind of looking at not all cause, but multi-cause mortality from this one event, and then thinking through the biology of each of these endpoints, specifically where they had this finding that death from cancer did not change as a result of these events. And that was counterintuitive to me, because I would expect that it would relate to treatment access, that people who had cancer that their treatment was disrupted in a way that was not good. And so in that was a little counterintuitive to me, because I would expect that some of these other death outcomes would be associated with limited access to treatment during an extreme weather, during and after an extreme weather event.
It's interesting that you say that, because I went in the exact opposite direction with cancer. I actually thought the cancer was I don't know why they put it in there, but I thought it was in there specifically to deal with the concerns that we had around confounding. Because you're right that obviously if there is a extreme weather event, there will potentially be disruptions. But I don't know that those disruptions are going to be long enough for a large enough sector of the population that you would expect it to impact cancer outcomes. And so I thought it was in there to demonstrate the fact that we don't see an effect on cancer outcomes would suggest that the effects that we're seeing, the other effects that we're seeing, are not explained by just confounding.
Treatment or by access to, so that you're saying that you interpreted it as if treatment was not disrupted enough so that the causes that you could think about were not due to lack of treatment.
Yeah.
And as such, it makes the other findings more believable because we wouldn't expect a difference in cancer related to a hurricane.
Right. I think I had
I would have expected if there was limited access to treatment, I would have expected. No, you did not.
I think I felt the same way. I think I believed that the reason why cancer was included is because if we did see meaningful differences in cancer post-hurricane exposures, then we would expect that a lot of these results that we're seeing are not because of the hurricane exposure itself. It's because of that disruption to care that happens in the wake of a hurricane. And I do think that this is a really interesting question. Some of the implications that I see that I think are very interesting in that is that by using this distributed lag structure in this model, we're able to look at not just the immediate aftermath of the hurricane, we're able to look at extended periods after the hurricane. And so I think, seeing the bumps that happen in mortality rates in like a 6-month lag, looking 2 months out from a hurricane and seeing increases in infectious disease outbreaks, it all kind of tracks to me.
Yeah, it does. I thought that was, my initial skepticism with the lag model was, do we really expecting to see, an effect of a cyclone 6 months later on, something like cardiovascular events? I was not. But then I realized, no, that's the point. That's what they're trying to show here is that the increases that you're observing are actually following kind of the expected pattern. Maybe the magnitude is off a little bit, but the pattern makes a lot of sense that particularly with injuries, you see the effects right away. With some of the other events, you see a little bit of a delay, but not much. And then sort of things come back to normal. One question I did want to ask is my understanding here is this is a Poisson model. So it's fitting relative estimates, right? So these 3.5%, that's a 3.5% relative increase, right?
Yes.
This is just sort of my general annoyance with the models that we use, but it seems to me that the absolute matters here. We'd actually want to know how much absolute increase is there in mortality, and you don't quite get that from this.
They do present some absolute estimates deeper in the text, but they're small. Some of them are less than one person or kind of 0.3 to 0.6 estimated increased deaths. So they are small absolute effects for many of these, except for injury.
Except for injuries. And a lot of it is you wouldn't expect a large absolute increase because the absolute number of deaths isn't massive, but it's real.
Right. And I just want to make a couple of additional points on that. The first one is just, again, going back to what we were mentioning earlier as potentially one of the limitations of this paper. Deaths is the most extreme outcome that happens during a hurricane. Really so there could be a lot of other clinical outcomes that are highly relevant that we're not fully capturing in this version of this study. You could imagine looking across all of the patients who are having increases in emergency department visits for cardiovascular disease or for neuropsychiatric disorders. And then the other thing that I want to mention is that in the context of the climate and health literature, we are interested in the impacts today, but we're also interested in the implications for future impacts as we see more frequent storms that are more severe and longer lasting in duration. So I think if you take the implications for mortality outcomes or morbidity outcomes today, I think it provides us with a framework for what we would expect to see under a climate change scenario in the future. So, current impacts might be small. We might expect those to expand in the future. So those were the 2 points that I wanted to bring up.
Agreed. And I do also want to clarify that it is worth remembering their model is per day of increase. So we're not talking about event versus no event.
Exactly.
This is for one additional day. So 10 additional days, would increase things even more. So it's just worth putting those numbers into context. Any last points anyone wants to raise about this study before we move on?
I wanted to ask a question of the two of you. Why was this a JAMA paper? what about this analysis in particular made it worthy of JAMA? Because in general, there are not that many environmental health studies published in JAMA. Most things are medical kind of, clinical trials or things along those lines. And so it's more unusual in our field to have a paper like this published in JAMA. And I was wondering, what was it that you think stood out most with this one?
I think that there is a rising awareness of the importance of climate-relevant extreme weather exposures and the impacts on different health outcomes. And I think that this study is particularly well done in terms of the modeling framework that they've put together, in terms of the data that they've leveraged, in terms of the fancy maps that they've made, and the way that they've taken into consideration indicators of particularly vulnerable populations like the elderly and people living in higher SVI areas. And so I think that it brings together a lot of the different attributes that we're most concerned about when we're looking at the relationship between climate extremes and health outcomes. And I think for that reason, it has a lot of clinical relevance and a lot of implications for treating people who are exposed to these extreme weather events. And I think that's what makes it a JAMA paper.
Me too. I think it's exactly that. I think it's a very well done paper. I mean, it has limitations as we talked about, but it's a very well done paper, and it's a topic that I think is so timely and of interest. I mean, we could talk about it in a second, but there was a Supreme Court ruling today about the EPA's ability to regulate the coal industries, et cetera. I think this is a topic that people care a lot about, and in addition to being good work, was well placed to get headlines. And then I think that's why it's a JAMA paper. All right, before we move on, I just want to point out, I did look it up, and from what I found, they make a distinction, or there are three terms: cyclone, typhoon, and hurricane. And what I read is hurricane is a cyclone that is in the North Atlantic Ocean or the Northeast Pacific, east of the international date line, or the South Pacific, east of 160 east, and with sustained winds that reach or exceed 74 miles per hour. So then what is a typhoon?
I don't know.
There you go. I don't know.
I'm stumped.
I wouldn't venture a guess.
I'm totally lost.
I think it's safe to say that they're all bad storms.
Bad. Yep. I also want to recommend that people go, you can't do this on a podcast, but there are some maps in here that are really, really informative. I mean, you can just sort of, a picture is worth 1,000 words. You look at these right away and you can see the areas of the United States that are most prone to cyclones, and then also prone to hurricanes. And surprisingly enough, we here in Massachusetts are actually, we're not in the dark red area, but we're in there. And I just, you live here, that, but you don't think of the north of the United States as being in the pathway, but we
also
are.
Commending just the figures for the students who are our listeners to come check these out, because they are really, it's really easy to look at the figures and very quickly glean their core points. I thought they were really well done.
Yep. Okay, so for our second segment, as I said, we're going to be following up on this strategic research directions focus areas of the School of Public Health here. And so we're going to talk a little bit about this article in the New York Times called "A Hotter World: Climate Change's Effects Are Already Unequal" by German Lopez. And it was published on June 2nd of 2022. And, I would say this article makes a lot of points that I think probably many of us are aware of, but just making very clear that those who have contributed most to global warming, namely us, are not the ones who are necessarily suffering the greatest consequences of global warming. So they specifically talk about India, talking about it's home to 18% of the world's population, has emitted only 3% of the planet's greenhouse gases, but is suffering from climate change in very dramatic ways. So over the past 3 months, a heat wave has devastated North India and Pakistan, with temperatures surpassing 110 degrees Fahrenheit. So obviously, those who have contributed the most to the problem are not necessarily the ones who are the most likely to be experiencing the problems. I have to admit, in reading this, it also reminded me of COVID and COVID lockdowns and the unequal distribution of the impact of things like lockdowns and stay-at-home orders. So it's not particularly surprising, but it is devastating, and so seems like something that we wanted to talk about further. They also make the point that countries with less wealth are also more likely to be closer to the equator, and also have more poverty and fewer resources to adapt. So they are already in a position where they are more likely to experience the impacts of a warming climate, but have less resources to be able to deal with it. And as we also noted, here in the United States, there was a Supreme Court ruling today that hamstrings the ability of the United States government to regulate a lot of these climate changing pollutants. So the question is, I mean, what if we do nothing, what are we looking at over the next 10 to 15, 20 years? Is it a hopeless situation where, those of us who live in places where we can mitigate the impacts are going to do much better than other places? And if that's the case, what should we be doing?
I feel like, I don't know the answer to that, but I feel like one of the fascinating things from this short piece was this, they termed it the paradox, that countries that are able to adapt to climate change or mitigate the effects are the ones that have gone through this high emission industrialization process that led, and it's in and of itself causes climate change.
Climate change, and presumably are in a position to be able to mitigate it because of the climate pollution that they did. Which created the wealth, which leads to the ability to mitigate.
Right. And so we're kind of left in the end with this paradox of countries that have not yet gone through this high polluting industrialization phase are the least able to adapt and to mitigate the effect of climate. And then you have this kind of almost double, triple whammy.
Yes, exactly. And I think that this is a really interesting concept because consistently in the negotiations that happen at the intergovernmental level around how do we resolve this issue, this huge crisis of climate change, the concept that gets tossed around is, do we go on a per capita emissions basis or do we go on a gross emissions basis? Because once again, the population of India right now is over 1 billion people. And so on a per capita basis, the emissions aren't that large, but as you incrementally add each of those 1 billion people together, the overall amount of emissions coming out of India and other populated parts of the world that haven't had a chance to industrialize yet or are in the process of doing so is huge. But still, on a per capita basis, the U.S. is by far the largest emitter of these climate-forcing compounds. And so, having this discussion, the paradox comes up in a couple of different ways, right? So the people who are the most vulnerable to the adverse effects of climate change are not the ones who have benefited from the anthropogenic activities that have created the climate change. And also the people who are currently have the capacity to adapt and to try and mitigate some of the impacts of climate are the ones who benefit the most and who experience the most wealth in today's society from the activities that have caused this issue. And so I don't know that I necessarily have the right answer. I think, we definitely need to do something. We know, and you mentioned earlier, what should we be doing? What are we facing in the next 10, 15, 20 years? And one of the things that I think, those of us who are now working here in BU at the center, the new Center for Climate and Health, is that we've acknowledged that climate change is not a potential future threat. Climate change is something that's happening now. We see the impacts of more frequent extreme events, more severe extreme events, and we're seeing the mortality implications, such as the paper that we just went through. We're seeing a host of physical and mental health outcomes that are associated with climate exposures. So there are things that we can do currently to try and intervene and reduce some of the burden of disease that's associated with these extreme climate events.
And of those things that we could do, what do you think are the most promising and what are the most likely to actually happen?
So I think that's a great question. And one of the complexities, again, going back to a discussion that we had in the previous segment, is what is climate exposure? So one of the most relevant ones that we think about is extreme heat. That's the basis of this article, this short article. We have heat waves that happen here in the US. This isn't just something that's happening in India. And actually this year, I think there have been major heat waves. Of course, in the Southern Hemisphere, the heat season is in what we think of as the wintertime, so December, January. So there was a huge heat wave in Australia in January, heat waves happening in Argentina. There was a huge one earlier this year. Brazil experienced extreme heat. Right now, I believe there's an ongoing heat wave in the Midwest and Pacific Northwest of the U.S. A couple of weeks ago, there was one happening in Western Europe. So this is not something that's also very distant from us. So when you're talking about extreme heat exposure, we know that there are a couple of different things that work really well to try and reduce the adverse health impacts of extreme heat. So we have heat adaptation plans that have been implemented implemented by cities. They're focused on identifying those who are the most vulnerable and providing them with access to resources that can help them during these extreme heat periods. So some of the things are access to cooling centers. We know that air conditioning is one of the best ways to reduce people's heat exposure, for example. But even here in the city of Boston, the Boston Climate Adaptation Plan includes sustainable development, green spaces. It includes access to cooling centers. It includes a whole host of resources that are designed to reduce the health impacts of climate. And that's happening in cities all across the US. In a global health context, in places like India, where they're describing these extreme heat wave events of this summer, you can't do some of the same activities because you can't tell very vulnerable low-income populations to go to a place that has air conditioning.
Right.
They may not have the electricity capabilities to provide consistent access to air conditioning, or the places that do have air conditioning might be too expensive for those folks to be able to access them. So it's things like providing clean drinking water and freely accessible drinking water in public places. It's also things like increasing access to urban green spaces, because we know that green space is one of the mitigating factors in an urban heat island. So instead of saying go to the nearest shopping mall or go to the nearest movie theater, you might tell them to go to the nearest park, go to the nearest waterfront area and cool off in that way. And then the other thing that I think works very consistently, regardless of your global health context or regardless of your community, is relying on those community bonds. So making sure that we're checking in on our loved ones, our neighbors, that we're taking care of each other as members of a community, because the best way to make sure that people are okay is to, check in on the elderly when it's an extreme heat wave period and you know that your neighbor is living in a non-air conditioned place. So relying on word of mouth and spreading the information that way is very relevant. And I think the last one that I want to mention is that one of the reasons why I've been very excited to see more of these clinical journals that have these types of papers focused on climate and health is because I think that we have a lot of buy-in from clinicians who have recognized that these climate exposures are very relevant and very important for their patients. And so providing the collaboration between climate and health specialists and clinicians who are interested in climate exposures and the impacts for their patients is really important, because then those clinicians can be on the lookout for the signs and symptoms of extreme weather exposure.
It seems like there is a lot we can do, both to try to prevent the extremes of what's already happening getting worse, but also, as you say, mitigating it. And part of why I was interested in the last study, the idea of doing that at an individual level, is it would be really helpful to see what the mitigating factors are. In other words, what are the things that people could do to mitigate the impacts? And you could do that for hurricanes and cyclones, but you could also do that for heat events. You could do that for, pretty much anything. And I think that would provide us with some really useful information.
Mm-hmm. I just as a side comment, I was struck by your comment, Matt, earlier, and it was mentioned also in the article, kind of thinking about COVID and lockdowns and kind of what, is there anything in this experience that we've lived through over the last couple of years with COVID that can help us as we continue to prepare for climate change? And I think, there is obviously the parallel that the lockdowns had the worst effect on people who were the most socioeconomically vulnerable, who would lose their jobs if you could not actually go to work, while many people were able to work from home and kind of more or less continue their lives while remaining protected from COVID, and other people were not, to their detriment. And I think that that's one parallel. And I also was struck, as Amruta was just talking about, kind of community responsibility. There is learning in there from COVID as well, as we think about vaccination and we think about messaging about how to increase vaccination uptake. That one of the core messages was do it for the community. Even if it's not going to benefit you, do it for the community. And it did not work equally. It didn't work that line of messaging didn't work as well. And I think when we think about climate and the community, quote unquote, is global, where your actions in the United States are affecting people right now in other parts of the world, it's a hard sell. And, if it's even hard to make it, in your smaller community, I think the global community is very difficult. And so I was thinking about that as we were thinking about these potential strategies to increase awareness. And there's real challenges there.
I think that's right. But, one of the things that I want to just mention is that in my experience, and, I've spent time in the field, I've spent time going out and measuring air pollution exposures and measuring heat exposures and talking to different community members, whether it's in the US or whether it's in India and other contexts. But people understand what's happening. And people understand it in a different way than we might be talking about it as epidemiologists or as environmental scientists. But they do understand that there is something that's happening that is adversely impacting their health. And I think we don't have to go to those global communities to find those effects. We can talk to people. And I do agree with you. I think that it's much easier to bring it down to the level of discussions about the impacts that you and your neighbors are feeling as a result of these climate exposures. And maybe it's about having that discussion and having that conversation in a context that people understand it's a global crisis that has very local implications. And I think that's the key. And the other thing that I wanted to mention, going back to what we were talking about earlier in terms of the parallels with COVID, I think another thing that's really important is in terms of the vulnerability issue and aspect that we were talking about is that climate exposures don't happen in isolation. You might be only impacted by a hurricane, or you might be impacted by a hurricane that's happening during a heat wave or during a summer period that's very hot. There might also be a drought in your community. And so, one of these things that we need to think about, in addition to some of the excellent points that you've already mentioned, is that one of the issues during COVID was that, we were facing things like people being in lockdowns during extreme summertime periods. And we were facing, the interactions between different types of relevant exposures. And I think it was the added burden of all of these additional things that people were thinking about during the COVID lockdowns and then during the times when people were going about during COVID. And so I think, one of the points that I just wanted to mention is that climate is really a multi-hazard issue.
It's a really good point. And we had, as you said, we had hurricanes and cyclones during COVID, which required people to go to shelters,
right,
where they were then having to live in close contact with other people, increasing the risk of COVID transmission.
Exactly.
So it affects just about everything related to health and well-being. So, all right, I think that's a good place to leave it. But I find that a really interesting conversation, and you've given me some hope, which I think is not what I expected at the end of this conversation. So I'm really, really pleased by that. So let's move on to our last segment, which is our Amazing Amusing. And I'm going to go first this time because what I want to talk about is the impact factor. So for anyone who doesn't know, the impact factor is one not great, but very often used measure of the quality of a journal or the impact of a journal. And it's essentially the number of citations that each article gets on average over a couple of year period. And, it's one of those things that academics use to decide which are the really important and good journals to publish in. And it unfortunately gets used. Well, unfortunately, I don't know if it's right or wrong, but we know it's a problematic metric that gets used to determine things like promotion. So it's a controversial measure. In particular, it's controversial because it's an average measure and it's a measure that's very non-normally distributed. So that just because you publish in a journal that has a high impact factor, your article may only get 2 citations, but on average you get to 30 because there's a couple articles that get 1,000 citations. So it's not a great metric. But the reason I bring it up is there was this article in Retraction Watch. It's not an article about retractions at all, though, but they were just pointing out the fact that for the journal citation measures, the impact factors have been released for 2022. And for the first time, The Lancet surpassed the New England Journal of Medicine as the top medical journal.
Wow.
But not only has it surpassed it, it went from, and I got to get the actual numbers here, but it went from last year at 79.3. So in other words, the average article getting roughly 80 citations to 202 in 2022. New England Journal of Medicine also went up from 91 to 176, but Lancet went up even more. And in fact, if you look, all of the medical journals are actually going up. Partly that's because there's more publications, but the biggest reason is COVID. That there has just been so much focus on COVID that Lancet getting a lot of, COVID publications that end up getting a lot of citations from other COVID-related papers has just inflated the entire field to the point where, like, is it really even plausible that they've doubled in their impact in 1 year? I mean, clearly it's not, but so I'm curious what's going to happen next and whether next year things are going to come back down to normal, or maybe 2 years from now and New England Journal goes back above, but I'm also curious what it's going to do to the entire field. So my only interest in this article is in the fact that COVID is clearly distorting all of the metrics that we use for thinking about quality, impact, and also, thinking about promotion for, academic faculty. So I just thought it was a really interesting tidbit.
Well, it also brings up the issue. I know just from environmental health, in our discipline, a lot of people jumped into COVID to do work in COVID that didn't work in infectious disease before.
Yeah.
And kind of shifted, given the resource, your time is finite. And so however many publications they would have had during the pandemic, maybe they were all about COVID instead of being about their climate change or their original air pollution topic or whatever it was. But then at some point that will shift back.
Yeah,
and so, because you'd think the journals in our field then would have the relative decrease in articles published, and then would suffer an impact.
Articles published doesn't necessarily matter so much as
citations.
Just the citations,
but still,
if fewer people are writing, then there may be fewer citations.
But interestingly, the Journal of Exposure Science and Environmental Epi announced an increase in their impact factor as well. And now it's not, it's not from 79 to 202, but I mean, it's still up, if you look at it in the relative terms, it's still a pretty high jump.
That's significant.
Yeah.
In relative terms, though, that's exactly it. I mean, I saw somebody who was tweeting about this, saying, even if you look at journals with impact factors of 1,
going up to 2,
often going up to 2,
it's huge.
That's a huge change for them, and it's just, I don't know. It'll be interesting to see what's going to happen next. So
that's interesting.
Yep.
That's interesting.
Amruta, what do you got?
So I have. Speaking of the New England Journal of Medicine, there is a new fossil fuel pollution and climate change New England Journal of Medicine group series. So the NEJM group of publications has committed to publishing 1 article about climate change and impacts on health per month for the upcoming year, and hopefully that will continue into the future. And I find this really exciting, going off of the conversation that we were having earlier. I think this indicates the large and growing clinical interest in the health implications of climate. And so I'm super excited about that. I hope that everybody listening will take the opportunity to go and check out some of the excellent articles that have already been published, including one this month in the New England Journal that is a systematic review, an overview of studies looking at climate change impacts on children's health. That was one of the co-authors is Frederica Pereira from the Children's Environmental Health Center at Columbia University. So I think that's a fantastic article. But I hope that people will also take it as an opportunity to submit their own work to the New England Journal of Medicine. I think it's a really great way to get more publicity and more dialogue and discussion with clinicians around this issue of climate change impacts on health. And so I'm really excited about it. And I hope it provides space for a lot of up-and-coming researchers and researchers in the field of climate and health.
So when you proposed this idea, my first question was, why is this only happening now? This is something that very clearly impacts people's health in a way that you can detect it at a population level, right? We're not talking about, a small study with a targeted intervention where you can pick up an effect. We're talking about all-cause mortality type effects, which, affects everyone. Why is it just now that we're suddenly saying this rises to the level of New England Journal of Medicine committing to publishing papers?
I don't know the answer to that question.
I have a suspicion. I mean, and I didn't say this in regard to Robbie Parks's article, but I think research that documents these implications in the United States are viewed as more relevant of being published in the New England Journal and JAMA. I think that was in part not the entire novelty of Robbie's. I mean, it was a great paper, but I think the fact that it was focused on U.S.-based populations. I think there's a bias in these journals, and I think as there's more and more research led by Amruta and others in this field to kind of document the implications and the vulnerabilities in the United States, it grabs the attention of these high impact journals, and then they commit to it. And I think that ultimately is for the better, because then it highlights issues around the world. Yeah. If they open up these channels for people to submit particularly themed articles, which is wonderful. But I think, to me, it reflected that domestic bias.
And I think that maybe another thing is just that for a long time, we've been grappling with so many questions around, how do we even start to approach this research agenda? I think there's been a lot of exploratory analyses, and there's been a lot of, okay, so what is exposure to a heat wave? What is exposure to a hurricane? And these are not things that are recent. These are things that my advisor and, my postdoctoral advisor, my PhD advisor, my master's advisor before, Pat Kinney, who's in our environmental health department here at BUSPH, these are questions that people have been thinking about for the last 20 years. So I think that now that we've started to kind of agree as a field about the best practices for doing this type of work, and we're able to leverage large data sets so that we can look at communities across the U.S. And, as Jessica was saying, we can highlight that there are, in fact, implications of climate change in the U.S. I think that is a really good point, and that might be why it's come to the attention of the larger clinical journals.
I think all of that is true. I mean, I think the availability of data that we didn't used to have access to, that you could look at a lot of these measures more easily. But I also think that, it also has to do with the fact that it's not a biomedical intervention type thing that the New England Journal of Medicine loves. So I think there's a lot of different reasons. So really interesting. Jess, what do you got?
I have. So this is something a little bit lighter, I guess, but kind of fun.
we need that.
Yeah. Because it's also, I know our listeners are not here. It's really hot in here.
Oh my gosh. I am
very warm.
Air conditioning in our building. We're talking about air conditioning. It's pretty hot. So I found this piece. This was just online. This was in the Science News website. As we were thinking about climate, and some of my research going way back has to do with industrial meat production, industrial food animal production, and my work focused on the disease implications, the zoonotic disease. But there's a lot of environmental implications of food and meat production. And so I was thinking about, in the context of climate, what are foods that might be considered sustainable from a climate change perspective, and how tasty might these foods be to our palates? And so I was going to highlight some of these. These are the top 6 foods that are going to become more popular
and environmentally more popular because
they can be grown more easily in a changed environment. Okay. So I'm going to see what the group of you think about
this. Please say Oreos.
Okay. Number 1, millet.
Okay.
And did you know, millet, I did not know this. The UN has declared that 2023 is the International Year of Millet.
Oh, in my house, that's, we celebrate that every day.
This is big. Quinoa had that honor in 2013.
Wait, quinoa is not environmentally easy to grow, is it?
I don't know about that, but they're saying that millet is much more climate resilient than wheat, maize, and rice. It needs little water and thrives in warm, dry environments. So,
can you make pizza out of millet?
It is an ancient grain. I don't know, but you can turn it into beer, they're saying.
Oh, that's good.
So
there you go.
That's something. Okay, so millet is number 1. The Bambara groundnut.
I have not heard of that.
This is some sort of legume. And an understanding, this is something that I think is grown in Malaysia. I think that's what they're saying, that it could be something that could be either an alternative to coffee or an alternative to like an almond milk, that you could make a milk from this sort of nut.
I'm a little skeptical about the coffee alternative.
I agree with you.
High yield and drought tolerant.
There you go.
Okay, mussels. That's another one. I think
mussels.
Okay, mussels. I can get on board with that.
Mussels we understand because they're, the filtering bivalves and they filter water, very hardy. I remember I did a research study when I was in like 3rd or 4th grade on mussels, and I was so disgusted because they just, absorb like all of the
everything
from the water, and then you just pop them in. But mussels are there.
Good.
Kelp. We have kelp, and another one because it is resistant to, I think, chemicals in drinking water. Here's one I don't even know called enset.
No,
it looks like it's called the false banana. This is it's a drought-tolerant plant cultivated in Ethiopia that looks like a banana plant. It resembles the banana tree, although the fruit is inedible. So the false banana, and it's called the tree against hunger because you can eat the starchy stems, can be harvested at any time of year, making it a reliable buffer food during dry periods and famine.
Okay.
So enset, the false banana. The last one is cassava, which is the starchy potato.
Cassava, I'm on board.
That we've had before. We've had more. So anyway, we might be seeing some more of these items coming into grocery stores near us in the environment of climate change.
I'm skeptical about some of those, but some of them I'm on board with until they invent the false Oreo. I'm not sure I'm there. All right. Well, that is the end of our program. If you got any feedback for this or any other episode, or you want to suggest a study or a topic for us to take on, you could tweet us at @PopHealthEX, or you can tweet me at @ProfMattFox. Jess still doesn't have a Twitter available. Amruta, do you have a Twitter?
Yes, I do. It's A Sans Reason.
There we go. Or you can find us on the Population Health Exchange website at www.pophealthex.org. We want to thank Leslie Talalian, Assistant Dean of Lifelong Learning at the BU School of Public Health, for supporting the podcast, and Nick Guler for sound editing, and today video. Well done, Nick.
Nice job,
Thank
Nick.
you.
He's got like all these cameras in front of us. It's pretty impressive.
Are you? Is there any chance you could do like the Matrix thing where you spin around and we are frozen in midair? All right,
Great.
excellent. Thanks for joining us. We hope you've enjoyed it, and we hope you will download our next episode.